Welcome to MLE Masters. In today's video, we'll dive into cardiac anatomy, USMLE High Yield Edition. Whether you're preparing for Step 1, Step 2, or just want to solidify your foundational understanding, this session will simplify everything you need to know about the heart's structural anatomy. Let's begin with a comprehensive yet easy-to-follow walkthrough, from the chambers to conduction pathways, coronary circulation, and the clinical relevance that will help you ace those vignettes. Before diving into specifics, here's a quick overview. Cardiac anatomy is not just memorization. It forms the base of clinical physiology and pathology. You need to understand how the heart is built to interpret murmurs, localize infarctions, and understand conduction disorders. We'll cover 4 major areas: the chambers and valves, coronary and venous circulation, surface anatomy landmarks, and the conduction system. Each section will be enriched with clinical pearls and USMLE-style correlation. The human heart consists of 4 chambers: the right atrium and right ventricle on the deoxygenated side, and the left atrium and left ventricle handling oxygenated blood. The right atrium receives blood from the body via the superior and inferior vena cava, while the right ventricle pumps it to the lungs via the pulmonary artery. On the oxygenated side, the left atrium receives blood from pulmonary veins, and the left ventricle, the most muscular chamber, pumps it systemically via the aorta. The interatrial septum separates the atria, while the interventricular septum divides the ventricles. Clinically, defects in these septa lead to ASDs and VSDs, high-yield congenital anomalies tested often on Step 1. Now let's talk about the valves, the guardians of one-way blood flow. We have atrioventricular valves, the tricuspid valve on the right and the mitral bicuspid valve on the left. Then we have semilunar valves, pulmonary and aortic valves. These valves open and close based on pressure gradients, preventing backflow. When valves fail, either due to stenosis or regurgitation, we hear murmurs. USMLE loves testing murmur location, radiation, and timing, so mastering this valve anatomy is essential. Let's now understand the surface anatomy, a favorite for clinical correlations and physical examination questions. The right border of the heart is formed by the right atrium, while the left border is shaped by the left ventricle. The inferior border is mostly the right ventricle, and the apex of the heart, which we palpate during clinical exams, is made by the left ventricle, located at the 5th intercostal space in the mid-clavicular line. These landmarks are essential for cardiac auscultation, especially for localizing heart sounds and murmurs. For example, the mitral valve is best heard at the apex, while the aortic valve is best auscultated at the right 2nd intercostal space. Make sure you can match each valve to its respective auscultation area. It's a classic USMLE question. Let's move on to coronary circulation, one of the most high-yield areas in anatomy. The heart muscle is perfused by the coronary arteries, which branch from the ascending aorta just above the aortic valve. The right coronary artery, RCA, supplies the right atrium, right ventricle, inferior wall of the left ventricle, and critically the SA and AV nodes. The left coronary artery, LCA, divides into 2 major branches. The left anterior descending, LAD artery, supplies the anterior wall of the left ventricle, and the interventricular septum, often referred to as the widowmaker, due to the severity of infarcts here. The circumflex artery supplies the lateral and posterior walls of the left ventricle. Coronary dominance depends on which artery gives rise to the posterior descending artery, PDA. It's RCA in most people. This determines the infarct patterns and ECG findings. So pay attention to this concept. The heart doesn't just need blood. It needs to drain it too. Venous drainage occurs through 3 main veins. The great cardiac vein runs with the LAD. The middle cardiac vein parallels the PDA. The small cardiac vein accompanies the RCA. All these veins drain into the coronary sinus, which is a large venous channel that ultimately empties directly into the right atrium. Knowing these relationships helps understand post-MI complications, especially when discussing venous congestion or right-sided pathology. Let's now talk about the cardiac conduction system, the electrical backbone of the heart. It all begins with the SA node, located in the right atrium near the superior vena cava. This is your natural pacemaker, firing at 60-100 beats per minute and initiating the cardiac cycle. The impulse then travels to the AV node, located in the interatrial septum near the tricuspid valve. The AV node introduces a critical delay, allowing the atria to contract and empty their blood into the ventricles before the ventricles begin to contract. From the AV node, the impulse moves into the bundle of His, then splits into the right and left bundle branches, and finally travels through the Purkinje fibers which distribute the impulse quickly through the ventricular myocardium, ensuring a strong and coordinated contraction. Remember, each component has its own intrinsic rhythm. This system is key in arrhythmias and heart blocks, a favorite topic for Step 1. For example, AV nodal ischemia due to RCA infarct can lead to bradyarrhythmia or heart block. Let's connect anatomy with pathology, the key to mastering USMLE. The mitral valve is best auscultated at the apex, in the fifth intercostal space midclavicular line, a critical detail in murmur localization. An RCA infarct can affect both the SA and AV nodes, leading to bradyarrhythmias or complete heart block. An LAD infarct affects the anterior wall and interventricular septum, showing up as ST elevations in leads V1, V4 on an ECG. It's also the most lethal MI, hence the nickname Widowmaker. Valve defects like stenosis and regurgitation produce systolic or diastolic murmurs, and their radiation patterns can help pinpoint the affected valve. A pericardial effusion can blunt the heart borders on chest X-ray and, if severe, lead to cardiac tamponade, another USMLE favorite. This is why mastering anatomy helps you not just memorize, but diagnose. Let's wrap it up with a quick recap. The four chambers, their blood flow directions, and separation via septa are foundational. The valves ensure unidirectional blood flow, and any pathology here creates murmurs. Coronary circulation, especially LAD, RCA, and their branches, helps localize MIs. Venous drainage through the coronary sinus completes the circulation loop. Conduction system is essential for rhythm. Remember SA, AV, his bundle branches, Purkinje. And lastly, clinical correlations make anatomy relevant. Always tie it back to physiology and pathology. Thank you for joining in this high-yield review. If you found this video helpful, don't forget to like, share, and subscribe to MLE Masters, your go-to source for crisp, USMLE-focused learning. See you in the next video.